Hi, and welcome to Microbial Musings, a miniseries podcast on infection prevention. The Arizona chapter of American Academy of Pediatrics is proud to partner with the American Academy of Pediatrics and the Centers for Disease Control and Prevention's Project First Line to bring you this podcast miniseries. I'm Dr. Helene Felman, general pediatrician, member of the Arizona AAP chapter, one of their Project First Line ambassadors, and a member of the chapter's advocacy committee. I do have a financial disclosure as I'm the principal investigator of an Access-sponsored grant to study an AI tool to help diagnose autism. We hope you enjoy this podcast miniseries. Okay, so this is the second episode of Microbial Musings, and I have the pleasure and honor of sitting here with Dr. Nate Price, the newest infectious disease and immunization medical director, co-director for the Arizona AAP chapter. So welcome, and today we're going to talk about precautions. So I guess first, I want to understand some common illnesses that are prevented. Let's start with contact precautions.
So there's lots of different precaution options out there, and the CDC actually has a really nice website that you can go to that lists different diseases that you use different precautions for. And so we use some precautions for certain disease like organism types, and then some for certain disease processes. So contact precautions are going to be used for infections that are going to be transmitted by touching. Gets on you, gets on the patient, gets on the next person, that sort of thing. And so we tend to use it for things like diarrheal illnesses, and so things like norovirus, that sort of thing. Some of the respiratory viruses are actually contact precautions. So RSV, parainfluenza, maybe human metapneumovirus, those tend to be transmitted by direct contact rather than getting coughed on, that sort of thing. So that's what we tend to use contact precautions for.
Great. And then what about inpatient versus outpatient? I know it's is there a difference for contact precautions in those two particular settings?
I mean, some of the things will depend on the type of patients you're seeing. Some will depend on the diseases you're seeing. Some will depend on your resources. Mm-hmm. And are you going from person to person, which most people are. And so we tend to be more fixated on precautions in the hospital setting. Mm-hmm. I think some of that is sometimes those patients are at a little bit higher risk because they have more severe disease, but you can have patients with pretty severe disease on the outpatient side. It tends to be, though, we focus a lot of that on the inpatient side because sometimes we're more cognizant of transmitting infection, and they might be in a closer quarters on the inpatient side compared to outpatient.
Yeah, and then I guess along those lines, going back, like there are standard precautions, which I didn't mention at the beginning, but what's the difference, I guess, between standard precautions and contact precautions when you're in the hospital? And is there a difference too in clinic, especially when a lot of the patients that we see on the outpatient side, we don't know what they have, and halfway through our visit, sometimes we're thrust with a new symptom that might be suggestive of an upper respiratory virus. So I guess maybe first starting back to like difference between standard precautions and contact, and then maybe delve into like what to do if something comes up in the middle of your visit.
Sure. And and it's not just contact, like you mentioned, some of these other things. You have airborne, you have droplet, and the CDC and the WHO are actually in the midst of redefining some of those a little bit too. And so there'll be more information coming out on that. But it's similar principles. But basically, standard precautions are universal precautions, right? Anybody could have something. We especially focus on bloodborne infections, that sort of thing. And so if you're going to be touching potentially infectious body fluids, then you put your gloves on.
Gotcha.
And so those are your standard. And any of these precautions are really basically the same inpatient versus outpatient. It's just how you apply them to your situation. Yeah. So then you have things like contact precautions, right? You're usually using, in addition to just the gloves, you're using your gown on top of that. Okay. And it may be a washable gown, reusable, or it may be a throwaway gown. And there's various types of gowns that are out there. When you're talking about things like respiratory infections that are droplet precautions, those are infections where as you're talking, you're coughing, those germs can go out usually within a few feet of the person, and usually they drop down and settle quite quickly. So in those situations, we're putting a mask on. So some of those things you'll be using eye protection depending on which subversion of the infections you're dealing with. For things where the infection is going to sit in the air for long periods of time, we call that airborne. And so those are those droplet nuclei. that can sit there for hours, and you can walk by hours later and breathe them in and get them. So measles or smallpox are an example of that, where they can be super contagious, long-lasting. And so those are, when we use airborne precaution, that's usually where you have what we call the negative pressure room, where the air is entering in that room, that air is ported out separately outside the building. You're putting on a special mask like an N95, or you're wearing a special self-contained unit like a PAPR. So different things for different situations.
Definitely. And then I guess speaking of measles, I guess there are now regions of the country with active infection. And so how would you recommend that we go about preventing and protecting our patients from inadvertent spread?
So the stuff that we all know works, right? And it's difficult to implement sometimes, but vaccination.
Yeah.
The vaccine works very well. A single dose is around 93% protective. That second dose gets you up to 97%. We know that if the community is at about 95% coverage with the vaccine, you're probably not going to have outbreaks in your community. But fewer and fewer people are choosing to vaccinate their children these days, and you're having a higher risk of getting those infections and outbreaks. So it wasn't very long ago up in Maricopa County that they had a couple of cases. We had a case here a few years ago, but basically Arizona is now 89.9% coverage for 2 doses of vaccines in school-aged kids. So we have a high risk for having lots of infections around here.
Yeah, that's very scary. I think one thing that I sometimes forget, but whenever these outbreaks happen, I remind myself that the kids who are 6 months and up, like normally we vaccinate at 12 months and then again at 4 years, but the kids that are 6 months and high risk, like traveling overseas is a risk, and even to just Europe, which many of the cases come from, that we can offer families that are traveling a vaccine as early as 6 months. And unfortunately, as you know, doesn't count for that official vaccination record, but it is a way to protect them when they're traveling. So
that case that I mentioned a few years ago, that's exactly what happened. Is it was a child that technically was too young to be vaccinated from a standard vaccination standpoint, went to a foreign country in Asia where measles was much more common. By the time the kiddo came back was 12 months of age, but was older than 6 months of age, so could have gotten vaccinated. CDC is now recommending that if you are going to travel abroad, it doesn't matter where you're going, and if you have not been vaccinated for measles, you should be vaccinated. And if you're over 6 months of age, you can get vaccinated.
Yeah, no, that's great. A great reminder. Have you seen any or heard of any other new cases, I guess, here in Pima County? I know that those two in Maricopa recently.
Nope, I haven't heard of anything new, but again, it's just it's right next door, right around the corner. It's only a plane right away. So we've had quite a bit of measles in the United States already this year, and it's not predicted to get a whole lot better.
Yeah. Let's talk a little bit more about droplet precautions, and especially, I know I'm a general pediatrician, so I'm seeing kids in the office, and oftentimes I don't realize that they're having symptoms before I'm in the middle of that visit. I think now from COVID, I've just continued to wear my mask just because I never know. Not everybody follows that. What are your recommendations when in the outpatient setting, when you're faced with these upper respiratory infections, which are mostly droplet? What's a pediatrician to do?
It's a great question, and obviously everybody can kind of take a look at their situation and decide what works best for them. But there's a good case to be made for universal masking, and there's a lot of people that advocate for it. There is evidence to support it, but I could understand the reasons why someone wouldn't want to or wouldn't universally mask. I think it's going to be a case-by-case situation. If the provider has an immunocompromising condition, you may want to be a little more aggressive with wearing that mask. You're right, you never know when you're going to be around somebody who has infection and is contagious, and it's a matter for protecting yourself and protecting your patients. And unfortunately, a lot of these diseases are contagious before they're obvious that someone has the infection. You've got that pre-symptomatic phase.
Yeah.
And people aren't always upfront or not always self-aware with what their symptoms are. So, for example, a while back when we were relaxing the universal masking for COVID, I still wore my masks usually, but there was a day in clinic where I had 2 patients coming into clinic that did not have respiratory disease. It was just a follow-up, and I was just being a little lax, and so I was running a little bit behind behind, I ran into the room. And I was talking to the patient, and while I was talking to them, they coughed right in my face a couple of times, and I asked them, have you been having symptoms? And they said, oh yeah. And they had already gone somewhere else and gotten a COVID test, and they hadn't had the results back. And then about an hour or two later, they called me back and told me that they had tested positive for COVID, right? And so neither the patient nor I was wearing my mask. And those things are going to happen, right? So it's not a bad idea to just wear a mask all the time, or at least be pretty aggressive with screening your patients and saying, and if they have any sort of symptom at all, throw the mask on. It's probably going to be more likely to protect you than to harm you. But again, you can look at the situation and see if it makes sense for you.
Yeah, I know a lot of my colleagues who are against the mask in a way, in just that it kind of limits your engagement with your patients. But I think for me personally, like, I'm doing it to protect like family members at home that I'm not immunocompromised, fortunately, but they are. And so it's just protecting them has been kind of how I've operated. And I have universal masks, even though we're not expected to. And also, it just helps to keep me from getting sick, because if I'm sick, I can't see patients. And that's kind of how I describe it to my patients and families.
And it goes the reverse too, right? Like, for example, I have kids at home, and it seems like there's not very long of a period of time when one of them or the other has some sort of respiratory symptom, right? And so at any point in time, they can give it to me, and I can be pre-symptomatic and contagious. And as I'm going in to see my patients, I might be contagious to them, but not have symptoms yet. And so I tend to be fairly aggressive with masking still for that logic. Yeah. But again, it works differently, it may work differently for different people as far as what works for them, what their concerns are, what their abilities are, and what their interactions are with people.
Yeah. So let's get back a little bit to precautions. I know we talked about contact precautions, and you gave the example of norovirus. I think in the clinic, anybody with kind of a gastroenteritis picture like norovirus, I tend to think that maybe I should be wearing a gown, even though I don't always wear a gown and gloves. I try to wear gloves in those situations. For droplet, you mentioned respiratory viruses. I think the classic ones would be RSV and flu as droplet precautions. Is that correct thinking, or?
Actually, RSV is actually a contact.
And so it's just contact.
So it's interesting. Some of these viruses, you're going to cough them out and infect people, and some of them it's going to be that close contact. So things like RSV, parainfluenza, and maybe human metapneumovirus, they actually may be more of a contact transmission rather than a droplet. The other thing to always mention, though, in conjunction with these other precautions is hand hygiene, right?
Oh, yes.
Hand hygiene.
Yeah.
Wash your hands on the way in, wash your hands on the way out.
Yeah.
And the hand sanitizer works really remarkably well for most things. There's a couple of things that it may not work as well. For example, C. diff or norovirus, you're probably going to want to use soap and water. But for most of the bacteria and the viruses, the alcohol-based hand sanitizer works very well. So if you do that really well, then you've got a good chance of your other precautions working and helping in preventing these infections.
Great. So I guess then for the droplet, what are the top kind of like 3 or 4 that you see that are droplet precautions?
So influenza is your major one, and probably rhinovirus, enterovirus, those sorts of things.
Okay.
So your regular run-of-the-mill, the rest of it kind of thing. And then we talk about, sometimes not necessarily the organism itself, but the disease process. And so some of these kiddos can't contain their secretions very well, and so they'll be drooling all over themselves, or sneezing and mucus and all that fun stuff, right? And so it may make sense to have both droplet and contact. So when we have these little kiddos, at least when they come into the hospital, we do worry about taking infection from person to person because we're in close quarters. And so we tend to, from a syndromic standpoint, put them on both droplet and contact, because we often aren't doing a test to know exactly which virus they have. And so, similar thing about diarrhea. If it looks like it's infectious diarrhea, we're just going to put contact precautions on until we know better what's going on, and seeing if they can contain their poop and that sort of thing. So. Which
is not always possible with kids under the age of 2 who aren't potty trained. Let's talk a little bit, and we've already talked about measles. What are some other airborne illnesses that we should be careful about in both the inpatient and outpatient setting? Like, when should we be getting out our N95s? When should we be putting on eye protection? Like, what sorts of symptoms or what sorts of diseases do we have to be careful about?
So you mentioned measles is the major airborne player. Chickenpox is another one. Tuberculosis is another one. COVID is a kind of in-between. And there's some data for and against. It seems like for the most part it can linger a little bit, but not nearly as much and as virulently as things like measles can. So yeah, I mean, and you have to be thinking about it because those things we're not used to thinking about and they can sneak in. And so it's not uncommon that someone with tuberculosis is unrecognized as having tuberculosis and they're not in the right isolation, or even measles or chickenpox, and that's fairly common because those are fairly rare diseases for us. Have to be paying attention to that. So if ever anybody says there's a patient with vesicles, my first question is what's the distribution and are they in multiple stages? And if they say they're in multiple stages, and I think, chickenpox, put that person in airborne. And if you stick a person with regular herpes in airborne precautions, then no harm, no foul. But if you missed sticking a chickenpox in airborne precautions, you're going to be telling a lot of people they've been exposed and may have to do things like give them varicella immune globulin and that sort of thing.
I guess in this age of not vaccinating as often, that's more and more of a concern because we do have a vaccine for varicella, but I don't know what the uptake is in this state or this county. I don't know if you know that off the top of your head.
I don't know the stats off the top of my head, but you're right, it's there, and you can rarely even get breakthrough infection even if you have been vaccinated. But we also have a lot of folks that come from places where vaccination is for chickenpox is not standard. So
that's true.
A lot of the immigrants that we have can have infection. And so that's often where we see some of these infections happening is in some of the places where these folks have been congregating, and then it can kind of get into other people that are not immune. So
gotcha. Well, in our last few minutes, I guess it was all the rage when we were starting with the COVID pandemic, the donning and doffing process. And I think all of us were trying to make sure that we were donning our precautions in the appropriate order and doffing them in the appropriate order. I was hoping we could just spend a few minutes reviewing the process for each of the different types of precautions. So just as a reminder for everybody to make sure we're not spreading the wealth.
Yeah, the big thing is just recognizing surfaces exposed to the patient are going to be contaminated. So you don't want to be touching yourself with those surfaces. And so you're going to be careful with your gloves. You're going to be careful with where you're touching on your mask and your face shield and all that kind of thing. And so again, hand hygiene, right? You wash your hands before you put your protective equipment on. You wash them when you take them off, or hand sanitize, depending what the organism is that you're worried about. And then sometimes if you accidentally touch something, you hand sanitize in between. And so if you're talking about like contact precautions, you're going to hand sanitize first.
Okay.
Then you're going to put your gown on.
Gotcha.
And you're going to put your gloves on, right?
Okay.
You're going to, in all that process, you're going to make sure your gown is well attached in the places it needs to be attached. And some of those are Velcro if they're the reusable, or tying if they're the reusable, or the the ones that you can throw away. And so some of them will have just a little loop that goes over your head. Sometimes you have to tie, but again, as long as you've got that all in place, you're good to go and go see the patient. When you come back out, again, it will depend on, is it a reusable versus a disposable? For us, and where I tend to practice, it's usually disposable. And so what you can do is you can grab on the side by your chest, and you've got everything on still, and you're only grabbing the outside stuff with your gloves on, and you can actually push forward and break the whole thing and have the whole thing come off. So now you have it in your hands, and now you can get the gown off, again, touching the outside and pulling it off along your arms, and you can kind of crunch it up into a ball, not aggressively because you don't want to be spewing out stuff, but you can kind of get it crunched down a little bit. And then, again, you've got the outside stuff now kind of folded in on itself, and now you can grab the inside of your glove with the inside of the gown and pull your glove off and do the same thing on the other side, always grabbing the insides with inside like your skin and not touching the outside. Now you can throw all that away and then you hand sanitize. If you had, say, a reusable gown that's going to get laundered, you take off your gloves. By your dirty glove, you're going to grab the outside of the glove and pull that off. And then once you have that off, with your hand, with the skin, you're going to pull the underside of the glove and pull that off.
Okay.
And then now you're going to grab your gown, but you're going to grab places that weren't touching the patient. So not your arms, not your front area. You're going to reach around and grab those ties that shouldn't have been in contact with anything, untie, and then can pull it off forward so you're not coming into contact, and then you hand sanitize.
Gotcha.
So that would be your
contact.
Your contact.
Okay.
With the droplet, again, you don't want to be touching the front of the mask because that's where you've been breathing it in, and in theory those particles are on there, usually the viruses, and so you don't want to be grabbing the mask and pulling it off. You want to be grabbing the strings, the straps, and grabbing them there and pulling them off. Again, if you touch the front of the mask, then hand sanitize and then take it off. Same difference with your face shield. You're not going to want to grab the shield, the part that's been, in theory, in contact with those infectious organisms. You're going to grab the back and pull it off. If you are wearing a mask, you're not going to want to pull that off in the room. You're going to want to get out of that room before you do that, whether you're in an ante-room versus out of the room entirely. So, and again, hand sanitize after you're done.
So you want to make sure you put your mask on before you enter the room and keep it on, and then keep it on when you exit, not taking it off until you've exited that room, regardless of droplet and airborne, but probably more important with airborne, I would guess.
Airborne and droplet. Anytime you're going to be close to the patient. You're right, with the droplet, if you're several feet away, you're probably fine. But most of the time you're going to leave the room before you do it. Gotcha. When you're dealing with contact, you want to take that off before you leave the room, unless you have a special anti-room that you do that specifically, because the goal again is to separate the patient from the outside world and not bring the inside the patient room to the outside world with your stuff.
I feel like fortunately in most inpatient settings there is an ante-room, not always, but I feel like a lot of times there is. It's not the case in our outpatient centers, which half of our locations don't have negative pressure rooms. So we're just doing the best we can with the resources we have.
Exactly, and that's the key, right, is to see what you have, see what makes sense. So, for example, you don't have a negative pressure airborne room and somebody with measles is coming to the clinic. Ideally, they've called ahead. We know that doesn't always happen, but sometimes we do. Yeah. Sometimes they say, hey, I think I have the measles. Well, first off, you can decide, do they need to be seen at all? And that's hard to do over the phone, obviously, but some things can be just dealt with at home with close follow-up, especially in this age of video. But if someone needs to come into the clinic and you know ahead of time, then you do everything you can to keep that patient away from others and put a mask on that person. So people who have TB, chickenpox, measles, stick a mask on the patient and you're really going to decrease the chance of them exposing to other people. Don't have them in the waiting room. Meet them at the outside. Bring them in. If you can bring them in through a separate entrance where you're not going past a bunch of people, do that. Find a room that's out of the way that you can keep them in, and then keep that mask on as much as possible on the patient themselves while you're evaluating them, and then try to again do the reverse and get them out to where they're not going to be around lots of people where they're going to be contagious. The other thing you have to be aware of is that again these things tend to stick around in the air, and so one thing people look at is how often does that air recirculate, and so they say at least wait a couple of hours before reusing that room, but it will really depend on your clinic what those air exchanges are. And again, there's stuff on the CDC, and you can ask your infection prevention person if you have one, how that applies and what you should do to wait and that sort of thing.
Excellent. Well, that is overtime. So I think we've talked about a lot of things. Thank you so much. And I hope that none of us get exposed to anything, and that with all these excellent recommendations, we're going to protect ourselves from all of the viruses and bacteria that are out there. Thank you again so much.
Thank you.